property, but just having the appropriate mechanisms for people to come in and out of hospital. I don't know if your hospital is different than ours, but one of the things that we always talk about is if you were going downtown Toronto to visit the Minister of Health or any office of the Ministry of Health and Long-Term Care, you'd be asked to sign away your life, right, and wear the appropriate badge. And there is very much strict protocol on access. Whereas hospital, it is, there are certainly some departments with control access, but generally we're an open doors, open door facility. So some things to think about, and we are going to be getting an update on our perimeter risk assessment shortly at our next Workplace Violence Prevention Committee. And I know for a fact that that will be one of the things that will be put on the list to do.
I want to say that Toronto East, and I don't know what type of security firm you have here, or whether they can, we were talking about it, we're not sure, but whether or not they can put their hands on patients. I think this is something that the committee should absolutely be looking at. I've just had to engage, and we were doing an appeal at the Labour Board for another violent incident that happened across the province. And so just looking at, what facilities across the province actually have security that can put their hands on patients, but they work with the care team. And I think this is where there's this paranoia in hospitals about, if we have security, they're going to hurt patients, right? We need to, honestly, you need to get over that, because they're working with the care team. You need to let nurses be nurses, not be security guards. And when you've got nurses sitting there trying to restrain patients, don't think those patients who have been violent aren't remembering that caregiver and don't come back. And and the psychological trauma that it places on the caregiver to actually, be beat up, be assaulted, be verbally abused and everything else, when you can have a security team like Toronto East, who, and if Clint was here, what he would tell you is 10 years ago, I think he said that they were applying force at Toronto East 54% of the time. And with the enhancements to the security team and the training that they provide to their security team, they've reduced that to 8% of the time that they're actually applying force. So there is huge value in having the proper security team working with the care team. And they work so well together. Like, I don't think that anyone at Toronto East would say get rid of our security team. And in fact, Rob Devitt and Clint would say it's the one area where they would not cut in the budget is in security. So I would really do a reevaluation of what your security team is allowed to do. I know Guelph General just had the big shooting down there. They did not have the proper type of security. They are now having the proper type of security coming in, being retrained. So you shouldn't wait for an event to happen that's so significant to find out what your failures are in the workplace.
So one of the obligations with workplace violence prevention is having some way of immediate summoning of assistance in the event of a workplace violence incident. And so we have chosen to go with Vocera, and it is like a Star Trek walkie-talkie badge. And I think the success for us has been that this tool is not just a safety device. It is actually an efficiency tool. So it's a communication tool, so bed allocating and nurse call and many other day-to-day functions actually get performed solely through Vocera. So I think the research tends to demonstrate if you give somebody a personal safety device and it can only be used as a personal safety device, the success of that tool is very, very limited. So early on, we decided that if we were going to spend money and implement this summoning assistance tool, that we would make sure that it was usable for other basic healthcare or service functions. So certainly, it seems to have worked for us. One of the things that it does is just so you tap it once and you call who you want to communicate with. If you double tap it, that's the panic alarm that goes directly to the protection services team, and not just one guy. It's the whole. It opens to every protection agent in the building. Whereas before, if you picked up the landline, you'd phone a central call center, and that central call center would then call your security guards. So the reality is the implementation of this device has created great efficiency for not only safety, because code white response times have been reduced by 50% for implementing this tool. But it also has provided business efficiency, patient care, support services efficiencies.
I can say across the province, a lot of employers, when they start looking at different devices, remember the legislation says that the employer has to have measures and procedures in place to actually summon immediate assistance. That's what section 32 point whatever says, right? So you have to put somewhere, I won't get into legislation, but it does say that. But a lot of employers are putting in place screamer devices. You can't summon assistance, that's a noisemaker. And then when you think about it, are you putting screamers, like, you know, you push a button and it just releases in a high-pitched tone, in a mental health unit, for instance, which is going to agitate the patients even more. You really have to think about what you're putting in place, because it may not be proper for the clientele that you've got and the customers that we have. So, you know, this type of device in all of the facilities that have it, that I'm aware of anyways, the members are extremely happy with it. They can't say enough good things about it. The other devices that we're hearing employers are going with, yes, they can call security. They have challenges with staff wearing them. Everything that Nancy was talking about. Challenges with staff wearing them because it's not an integral part of the work that you're doing, right? So just something to think about, because you spend an awful lot of money when you do put in place these devices. And if you're going to do it, why not invest a little bit more? And actually, Rob actually mentioned that, was it about the hard wiring, or how he saved money by putting these devices in because of not having to hard wire everything? Or I'm not a technical person, but there was some cost savings in doing that as well.
To just elaborate further on your training and education question, here too we did do the train the trainer module. So for the first, I'm going to say 6 months, probably less than that, we used solely the professional trainers from the vendor, but the commitment is right from get-go that our own in-house, we would create our own in-house trainers. So, you know, I'm sure you're not much different, if at all, from any of your comprehensive, you know, education and training programs. I mean, there is so much mandatory information that has to be shared, rights and responsibilities, some of the basic facts. So we cover that off through either module. But then what we offer is a half-day workshop where staff and physicians participate in a practical hands-on, it's a full day. The morning is about practicing de-escalation techniques, talking about the tools, behavioral assessments, patient flagging, education, and then in the afternoon it's really the physical safety techniques in order to disengage in the event of a physical attack. So not unlimited funds to spend, train the trainer module seems to be working so far. And what is unique probably at our hospital, and we've incorporated into our workplace violence prevention training, is we have a very high commitment to emotional intelligence training. So we offer every new hire 4 hours minimum of emotional intelligence training. And then at leadership level, you can have anything from a full day to 2 full days of emotional intelligence leadership training. We've now started incorporating the emotional intelligence, pieces of the emotional intelligence training into the workplace violence prevention training. So, you know, some people get personally triggered when they start to see conflictual behavior or escalation in aggressive behavior, and may or may not have the skills to minimize, to help somebody de-escalate, be it a patient or a family member or the general public. So it's just training to sort of make everybody aware that everybody comes into hospital not necessarily on their best day, and that they may have some, you know, significant challenges, may easily get triggered, and our response to their triggering may also, you know, be something that we need to be aware of and learn some strategies to help us and others better cope. So happy to chat further about sort of what that looks like later on. Another unique piece, of course, we have the aftercare program, if you will. So what do you do in the event that there has been an incident of acting out or violence? And we offer a lot of different things, probably all familiar to you, from EFAP to on-site crisis counseling. Certainly we rely on the intimate knowledge that our union stewards and LROs have about how to best support individuals. And one thing that I think is unique to Toronto East General is, in order to sort of really knock home the point that we really do want to hear about incidents, we want to learn from incidents, and we want to learn how to better support people in the aftermath of an event. We ask individuals who submit an incident report are contacted by our occupational health and safety nurses and asked if they would be willing to have a brief conversation with a member of the executive leadership team. And the conversation is not about hurry up and get back to work. It is, one, to express regret that the individual experienced an incident of violence, and to acknowledge that we as an organization do not tolerate violence, to ask the individual if they need different supports than what might already have been offered, to give the individual an opportunity to participate in debriefing in terms of if and when the individual feels that they might be able to contribute to a debriefing, and what their observations were, what they think the contributors were, what might be some of the resolutions to prevent a reoccurrence, then we make that offer to have them participate in the debrief. So, I would have to say that this goes a long way. Not every staff member or physician takes us up on that offer, and it's all voluntary, but the vast majority do, and it is an opportunity to be heard in terms of a person's individual experience and their own recommendations on how to prevent reoccurrence for one of their colleagues.
I have to say, the nurse who witnessed Lori being murdered stabbed 17 times in the workplace, and I had personal dealings with her, and one of the first things, and she said it many times, was no one ever called to say I'm sorry. Like, that was one thing she just couldn't get over, was that no one from management ever called just to say they were sorry that she had to go through that. And it was very traumatizing. She'll never return to work. I mean, but maybe she could have. Do you know what I'm saying? If the right supports had been put in place early on, and people just thought, it's a touchy situation, we should give her some space and avoid it. But the way that Toronto East is dealing with it, it's just to simply say, are you okay? We're sorry. It's okay to say we're sorry, right? And, is there anything that we could have done differently to even just get that input from that person? Because I'll tell you, our members across the province that I've dealt with personally that have been assaulted, every single one of them has a solution to a problem. I can tell you, there's not one that has not provided a solution to a problem. So management, whoever's management in the room, you have a huge opportunity to get information if you go and talk to the frontline workers. They know what's going on in the workplace, and they can help you find the solutions.
Won't spend a lot of time on this slide, but suffice it to say we use RL Solutions for our patient incident reporting and staff incident reporting. And so that gives us a wealth of knowledge, information, and data to mine, all of which is looked at both from a workplace violence prevention committee perspective, but also in the aftermath or coming into a debrief of an incident. We try to capture as much data relevant to the situation as possible. Incident debriefing. I alluded to this earlier, that we don't try to create a different process for debriefing on workplace violence incidents. It's the same process, and ideally the same sense of urgency that we use for patient incidents, severe critical. Think of a patient severe critical incident and how we rush to the table, you know, as a committee to sort of debrief, is this a critical, is it a severe, is it something else, do we need to report to, you know, MQPSC, et cetera, et cetera. And so we create the same methodology when we've had a workplace violence incident of a critical, severe, or moderate level, where we bring together the relevant people to the table quickly, including the staff or physician that has been involved, and create a fishbowl diagram talking about what are some of the contributors, what are the, you know, the immediate, longer term action plans, and we do attempt to sort of prioritize, you know, what's easily done but may not have that big of sustaining impact, what's hard to do and could have significant long-term sustaining impact. But our words of advice would be that we really need to sort of bring that cross-functional group together as soon as possible, and it doesn't need to be perfect. Plan, study, do, act, whatever it is. Use your continuous improvement lean methodologies the same way that you may be using them in your patients out of the business with staff safety violence.
And the other thing, as Joint Health and Safety Committee members, you're getting those, or you should be getting those accident reports within 4 days of every single accident happening, illness, accident happening. One of the key points that you should be getting is also the steps to prevent a recurrence. So for management, from workers, this isn't just about worker members of the committee looking at it, it's about management, all of you looking at it when you get it. And take a quick look, because I don't know who's completing them. Often in hospitals, it's the frontline supervisor who may or may not have had any training in how to even really do a root cause analysis. And so what you might find is a general statement which says retrain worker. Well, so the first question I always have when I see something like that is, retrain worker on what? On a deficient policy? Is your policy or your program really working? Do you even know which procedures you're going to retrain them on? Like, has anyone even thought about that? And what is it you're retraining them on? So you really need to take a look at it. And 9 out of 10 times, it's not about retraining the worker at all. It's about actually putting in place some other system that was missing, or is filling a gap that was missing. So really take a look at that. But here's an opportunity to have this team of people looking at incident debriefing.
Janice Ward is our quality and safety manager, and she normally speaks to this slide. She's doing an external review with North York General Hospital today. So this is one of the more controversial parts of our workplace violence prevention program was patient flagging, the recognition that some patients who come to hospital may act out in such a manner that warrants us having some manner of forewarning anyone else in the building that they should be careful, and that they need to sort of learn what the specific care plan, patient care plan for that individual is in order to keep themselves safe, the patient safe, and or other patients safe. So this is an excellent example of bringing together a small working group to come up with a patient flagging process. It's also another excellent example of courage, is I can tell you when we initially sort of floated the idea of patient flagging, that we had a lot of pushback from physicians in particular, from our psychiatrists, and some of our frontline nurses who really felt that we were going back to, you know, years gone by where we were putting mental health patients in red gowns and having them sit and emerge. So from a cultural perspective, there was some real relevant things to work through. But at the end of the day, you know, this is where our CEO stepped in and agreed to facilitate conversations with physicians and frontline staff. And we invited patients to participate in some dialogue. Long story short, we implemented the program. We made some minor amendments to the program. And in 4 years of a patient flagging program, we've had 2 patients or family members on behalf of patients come forward to inquire more about their loved one being flagged. And both of those incidents, it was, an opportunity to sit down and talk with the patient and the family about why the flag was put on. There was no, although there's an appeal process made available, in both of those incidents, the family or patient chose not to appeal the decision. So, the initial sort of pushback was we're going to be overrun with patients and families who are not going to be in agreement, or we're going to have willy-nilly flagging going on that just can't be justified. And to date, that hasn't been our reality, but it's certainly something that I know is very unique to every healthcare institution. And I've come to learn in the last 3 or 4 months that even within healthcare, I think long-term care facilities, their experience with flagging and where they sort of sit as a whole may be different than where we sit as hospital healthcare providers.
Well, that's interesting. I've actually just before going on vacation started talking to more of our long-term care people, and they are actually starting to even put the wristbands on some of the patients now, which is interesting. The biggest challenge we had, I think if you've got an ethicist, you'll have challenges with your ethicist. And that's where the CEO is really going to have to put the foot down and say, this is right, this is what we do. We flag for infectious disease. Why wouldn't we do it for workplace violence? Not only why wouldn't we, but the law actually requires you to, because the law says that you have to provide information about a person with a history of violent behavior to anyone that's at risk. Well, how do you do that unless you're tracking who's violent? And so it's one thing to track them when they're in the facility and they act out, but if you don't keep the flag on and they return, that individual supervisor who made the decision to remove the flag, quite frankly, should be charged under the Occupational Health and Safety Act if a person is injured. So should the CEO, so should NEDP, and that is what's starting to happen. We're starting to see a trend happening across the province now where the Ministry of Labour is starting to go in and is looking at this section of the legislation. So I would highly recommend, and we have lots of organizations that are doing this now. This is not just a one-off here or there. Just know, I don't spend as much time as, you've already done it, Hotel Do has done it. There's lots of hospitals that are doing flagging now to different degrees. But they're keeping the flag on mostly for life unless there's an appeal. And it's not about emphasizing the appeal, because you'll get into that as well. Let's put it in big bold letters that you can appeal. Is that really what you want? Because if I'm the person who's removing the flag and then someone gets beat up or killed or whatever, I wouldn't want that on my shoulder. Not only that, but the legislation actually said you had a duty to inform and you remove the flag. So you're going to have to justify and you're going to have to prove due diligence in the courts, right? So it's something that you definitely should be looking at if you're not doing it already, and it's a very inexpensive thing to do that can prepare workers. And one of the things that we didn't mention here is that when you're flagging, it's not just putting on a blue wristband, it's also about identifying what the triggers are so that you can provide a better care plan. And when patients and family members understand, it's so that we aren't going to trigger your loved one, it's so that we can provide better care so that they don't act out. You get the buy-in from the family as well, and the patient.
So happy to share more about our program if there are questions. So we have a number of metrics. What is relevant for us may not be a relevant metric for you, but suffice it to say it's a combination of direct violence metrics I think Erna mentioned earlier, including relevant security metrics, so use of force metrics. So to Erna's point that our protection service agents or safety agents really are an integral part of the patient care team, and the security use of force has gone down dramatically with the implementation of many components of our workplace violence prevention program. In terms of benchmarking, we of course participate in the OHA staff engagement survey, and those of you who are familiar with it know that over the years, particularly in the last 2 or 3 rounds, they continue to add more and more questions about workplace violence prevention. And so we continue to monitor ourselves vis-a-vis the OHA benchmarks.
Something Rob actually mentioned at the OHA session was that, I think he said, correct me if I'm wrong, but that you're benchmarking every quarter instead of once a year, but not the entire facility. So he'll do one section this quarter, another section, so that way it's constant improvement. You're not just waiting once a year to make improvement, you can do it every quarter.
So I think we'll wrap up and just sort of, we've tried to weave in a number of our lessons learned, if you will, and they may or may not resonate with you here at Belleville. But in summary, we would certainly say leverage your partnerships with all of your stakeholders and use their expertise. Don't reinvent the wheel. Our motto, which has worked for us, has been, don't be perfectly perfect. Go with something that is reasonable, and then commit to making it work for your organization. Integrate your activities of workplace violence prevention, of course, with your Joint Health and Safety Committee, but clearly, I think one of the reasons we've been able to move the ship as quickly as we have is as we've divided and conquered, and certainly used the Joint Health and Safety Committee as vetting, but not to do the day-to-day work. Continue to use quantitative data to sort of paint the picture of a business case, because you got to use whatever metric, whatever argument resonates with your leadership team and with your membership at large. Mentioned earlier that align your incident systems between patient and staff and violence as closely as possible. And everything from how you report to how you debrief, and where you share your story. So our workplace violence prevention incidents, when we have a critical or severe, they get reported not only to workplace violence prevention and Joint Health and Safety, but where it is where a patient has been involved, we present them to our Medical Quality and Patient Safety Committee, where all of the physician leads and the CEO are regular members of those committees. So we're integrating those debriefs into all of the key leadership committees, including the board of directors.
In fact, Nancy even picks up the telephone, and you've done this on several occasions, just say, oh, by the way, Erna, which I'm not the labor relation officer, which I'll just pick up the phone and say, oh, by the way, Erna, we had a critical injury. I just wanted you to know about it. Like, it's just, who else does? I had to say one other thing, which we didn't have the slide in this one, but one of the things we talked about is the incident reporting, and you're probably all wondering, did the incidents go up? Well, they did. This organization, like many, actually celebrates incident reporting. And so when they got the 2000 incident, the unit got a pizza party, and then balloons were all over the latex free, of course, right? But they celebrated in the cafeteria, and there was recognition to the person who reported that 2000 incident, and so they celebrate reporting of hazards. It wasn't just celebrating number 2000 workplace violence; it was the 2000s hazard. So they're really getting at all hazards, not just workplace violence. But if you're not doing something like that to encourage reporting, then you might want to think about something as simple as a pizza party for whoever reports that hazard, right? So you can start actually responding and reacting to it. And the other thing that we didn't get to here was, I think it was in 2014, you only had one lost time injury related to workplace violence, which is huge.
And I would just say to Erna's point, it's important to have a just culture. So we talk a lot about just culture and the importance of just culture when we're debriefing on patient adverse events, and that it's important not to sort of point fingers at individual culpability, that we're looking at incidents from a systems perspective. And you really do, our experience has been, you really do need to bring that just culture perspective to the table when you're debriefing on workplace violence prevention incidents, because of course an individual is probably already coming from a place of what did I do to contribute, so to sort of get them over that hurdle and thinking more broadly. It's really important that you make it clear that the incident debriefing is from a systems perspective as much as possible. And, you know, you're not going to have people reporting incidents unless they feel that it is for the greater good of the organization and for patient and staff care. So, that's a lot. A lot of talking. So, questions?
You kind of quickly went past how much your reporting went up after you implemented all this. I didn't catch.
So I don't know if we have it in this slide deck, but certainly our incident reporting, doubled, tripled related to workplace violence prevention reporting. We experienced the same increase in patient incident reporting as well. So again, it was all incident reporting. We don't sort of say, listen, we're not interested in hearing about patient safety incident reporting, but we want to hear about workplace violence reporting, and it just wouldn't fly. So all incident reporting is encouraged, and double if not triple number of incidents reported.
So did they do this online? Do you have like a computer program that they have to fill out?
Yes, so it's all online, easily accessible at unit level. And so for the executive team, if somebody experiences an incident, let's say at 3 o'clock on Saturday morning, and they report it as a severe or critical incident, then that automatically fires off to the executive leadership's cell phone, BlackBerry, whatever, iPhone. And so there's an automatic reporting of that incident to the senior leadership team, and expectation that we're very quickly responding to what is the incident. So it's not, the executive team and the CEO are not waiting for an incident to be vetted through, committee and or incident debriefing. Now, sometimes, the downside of that is sometimes we get beat about a critical incident that turns out not to be. Maybe it's a good catch, and somebody didn't understand the numeric reporting system, but hardly ever happens. The executive team want to know when an incident occurs.
I have to also say, and it's too bad Clint isn't here, because if you heard their security manager talk about security at Toronto East General, that's a whole nother presentation. We just had it present across the province, and it was fascinating to hear about the training that their security guys get, about the reports. I think he actually said there was something like 4,800 documented security incidents that his team responds to in this hospital alone. So, knowing how many incidents and how many could be injuries, I mean, there is a huge opportunity, cost savings alone, just from a WSIB perspective alone, right, in preventing injuries, to have the proper security team and the proper flagging system. And if you put all these mechanisms in place, you will certainly at least create the proper environment to hopefully start catching the hazards, getting people to report them when they become evident, not when it always happens that an injury occurred. And that's really what you want to do, to start preventing.
Can I ask, I'm from Pickton, have you involved the Ontario Federation of Labour in this planning process?
The Ontario Federation of Labour?
Yes.
So ONA used to be part of the Ontario Federation of Labour, and several of the unions have actually broken off from the Ontario Federation of Labour. We're working with a group of 8 that have broken off from there. So no, not in this particular program.
And why was it they broke away from the Ontario Federation of Labour?
No, that's a huge political question that maybe the leaders could answer.
Okay.
Yeah.
Okay. And what about the colleges themselves? We're all regulated, well, not all of it, but a lot of healthcare workers are regulated professions. Have you gone to the different colleges to document what their protocol is for healthcare violence, professionals speaking rudely or whether it's OPSU, not OPSU, sorry, the College of Medical Radiation Sciences, ONA, the lab tech, you know, the various colleges have their own jurisdictional approach to this. Have you applied that in any of your formats?
I can speak from the College of Nurses perspective. They have not been very helpful in wanting to answer any questions around this. So their advice is usually very evasive if anyone's ever had to deal with them. The Ontario Nurses Association, which is the organization I'm with, so we represent all the nurses for the most part across the province. You know, OPSU's got some nurses, QP's probably got some nurses, Uniform, a couple nurses, but there's healthcare workers all across the province. And I know OPSU just recently, probably about 6 months ago, had Toronto East also present to their mental health committee about this program. We've had the Ontario Hospital Association had us actually present to the Hospital Association. I actually sit on the Minister of Labour. It's called the Section 21 Committee. So our committee advises the Minister of Labour of trends that happen across the province. And so the minister is also well aware of this particular program, and we are actually now in discussions with the Minister of Health about setting up a provincial committee to actually look at some consistency. As a result of one of our nurses that got violently attacked at one of our hospitals in 2013, the chief prevention officer, who I also work very closely with, released about $600,000 to the Public Services Health and Safety Association to develop some best practice standards. And what they're working on, so you heard Nancy talk about the risk assessment tool that PSHSA has. So those tools hopefully are going to be, they've been upgraded, updated. There's going to be some on client assessment. They're just being piloted right now. They've been developed with employers and unions and frontline workers. And they're being piloted right now, and hopefully they become the standard. Part of that tool, the one on flagging in particular, will have a template. I don't suggest that you wait for the tools to come out, because Toronto East can help you and give you some of those, and South Lake has some good tools already as well. But when those tools do come out, we're hoping that other employers in the province who haven't done something will actually be able to kind of go and have those templates ready and available and start working on theirs. And one of the tools in the flagging procedure that we've developed is some Q&A around sharing of information and what information, because a lot of employers across the province are very reluctant to even provide the name of the person, the worker that was injured, right? Even though the legislation clearly says they have to provide it, many times they withhold that information, and that's not legally correct. And so PSHSA has now gone to a lawyer and has gotten a Q&A developed, similar to what WorkSafe BC did for their folks there in BC, and we're really excited about it. I can't wait for it to be released, because I think it will actually help a lot of joint health and safety committees and employers approach senior leadership to say, yes, we can provide this information, yes, we can flag, and here's how we do it. So it's not quite an answer to your question, but it's getting out there. The word right now is getting out there, and we're just waiting for the article. We actually published a paper, Toronto East and ONA together, and we're just waiting for it to be published hopefully in the next month as well. So stay tuned.
So the government has placed these regulations in effect, and yet they have provided no funding to fund support for these regulations.
I agree.
Is that what's happening? Because it seems it's like when every hospital needs to go to electronic records, every hospital develops their own programming, and it's very expensive, and it sounds like this is going to happen the same way. Each hospital is developing their own program, even though it's a province-wide problem, instead of allocating certain portions of it as common to everyone and developing it once instead of developing it three at a time.
Yes, you're absolutely correct. It's exactly what's happened, and that's one of the reasons why we went to the Public Services Health and Safety Association and to the Chief Prevention Officer to say, we need at least some best practice standards and tools that employers across the province can use that are standard. So rather than everyone having to reinvent the wheel and go through what we did here, what we've done in South Lake, what we've done in Hotel Dieu, like there's many employers that, you know, are spending years developing this stuff. Wouldn't it be great just to have, here's the template, let's follow it, and let's get things done quicker than, you know, you still have to put together your committees, but you know, there really should just be some standards. They put legislation in place and then they don't support it, and trust me, the Ministry of Health doesn't want to support it because then they might have to actually fund it as well. So it does leave employers in a lurch to have to find the cost savings and the money to do it, but in the end, I think Rob Devitt, if he was standing here today, would tell you that there is a cost savings. It may not be immediately seen, but there is a cost savings. And if nothing else, you're making the business case, because from a recruitment and retention perspective, it's huge.
Well, even the piece about security guards, what they can and cannot do. You know, every public hospital in Ontario should have the same type of security system allowed to do and restrain the same way. That piece should have to be reinvented in every hospital and should be mandated immediately.
Exactly, and that's actually something that if Flint were standing here, now that Toronto East and ONA is involved, we are trying to get some sort of provincial standard for security, but again, everything's going to take time, but we are advocating for that.
So we've got another question, I think, in the room. Was there not one over there?
Yeah, no, I just wanted a question and a comment. So when you were talking about your reporting system, I just want to make sure everyone was on the same page, that everything you said, we have. So our QHC Cares is for both employee as well as for patient safety. It also includes hazard and near misses. There's availability to report within there if there's a hazard or a near miss that relates to weapons or aggression or anything like that. So people should be, if they aren't already, reporting those kinds of things in QHC Care so that we can be trending, monitoring, etc. So just wanted people to know that we have an efficient, effective way to do that here. Secondarily to that, speaking about your slides that you had about weapons, what I'm curious about is, what is your policy at your hospital level as to who can do searches, or whether or not you're even able to do that to try and find weapons that might be available for use that aren't on patient? So if somebody were to come in as a visitor with a patient and they had a backpack, can you do anything about that? If somebody kind of said to you, "Oh, I think I saw them put a knife into that bag."
So I'm not sure I can answer the question in terms of the general public. Certainly when patients come in, we have an emergency, we have a security guard, right, protection agent, name, right at Emerge, and if the patient is going to be admitted, then there's a process for sort of getting undressed and gowning up. That includes search. But I can answer the question in terms of if we just have a member of the general public coming in to hospital, or let's say a friend or family member who looks suspicious, except when there's a specific observation of coming forward that somebody has seen, let's say a knife in a bag, then we would engage our security agents, and they would do an assessment as to whether the information was credible, and then they would search the person. We would not ask healthcare providers or anyone other than security agents to do that work.
So when you say that you have a process for searching a person in security, protective personnel do that, are you speaking of every patient or just your Form 1 patients?
Form 1, and anyone who's been brought in by police for violent behavior. So they may not be formed, but they've been identified as a violent, in the immediate aftermath of a violent incident. And there's one other category where I know that they do an automatic search, but I can't remember it.
So if they're brought in by police, the police don't search them?
They may, yes.
You research them?
Mm-hmm.
I might be able to actually answer your question. Search by a security guard is pretty much no different than it is with a police officer. No matter what you're gonna get called on, you have to be able to show reasonable cause for looking into that background. Like you said with the patients, if they're formed or they have a history of violence, that's a big reason. The general public, it's kind of a balancing act.
You know, and I get that, and I think generally that's why there's a policy that says here at QHC or GE, this is what we would do, so I'm just curious. Would you also include, when you said you couldn't remember what category, would that also include people who had been flagged with the blue bands that maybe had a history of having weapons that would?
I don't think we've had that come up specifically.
I could answer that if he was here.
Clint could answer it. Trying to think.
That's fine.
There'd likely be a police record if somebody came in either with weapon or with demonstrating intent to use weapon, we would engage the police. And that might trigger a response. Any other questions? Great. Thank you.